Alright, good morning. Welcome to the Automate Simple X-ray review course. So in this course, is targeted to review all the normal X-rays as well as the principles in ordering X-ray in a junior doctor's orthopedic posting. Okay, so without further ado, let's begin this course. Alright, so the two goals of this is to understand the key principles in ordering X-rays as well as the reviewing of X-rays that you can order, and just a brief glance at some of the abnormal findings and to recognize that it's all about pattern recognition. Okay, so what are the key principles? Is the rule of twos here. Two views, two joints, and two occasions. Okay, in terms of two views, it is usually orthogonal views, meaning perpendicular to one another, AP and lateral, right? Except in the hands and feet, there is an additional oblique view to remove the overlapping of the metatarsals. Then you want two joints. The principle here is that we want to avoid missing any potential injuries. So you want to image the joint above and the joint below if the patient complains of pain in those regions. Two occasions, we can always compare with old films if available to look for any changes. And finally, how to identify skeletal maturity, whether is it immature or mature, based on looking at the X-rays. Okay, so now I just want to give you guys some comfort because the reality is that reading X-rays is like how you tell a curved line from a straight line, right? So how do you know a line is not straight? You have to compare to an objective standard, such as a ruler. Yeah. Eventually, as you keep doing that, you may have an imaginary ruler etched in your mind. And with that, it is much easier to know whether a line is crooked or straight just by looking at it. But at the end of the day, you are still comparing to an objective standard. And that is the same for reading X-rays. Right? We want the normal X-ray to be etched into our mind such that we can recognize something that is abnormal. And that requires time. So you need to be patient with yourself and you need not rush yourself into this process. Okay, so let's start with the first principle. You need two views. Now, the X-ray is a two-dimensional imaging. Now, therefore, you will always need two views perpendicular to one another, ideally, to look for any abnormalities. So here is an X-ray of a ankle, and you can see on the anterior posterior view, you do not see anything abnormal. Okay, but on the lateral view, we see a fracture down the fibula. Yeah, in fact, on the lateral view, you can outline the fibula right over here, and you can see the fracture is within the fibula. All right, the key importance of asking for the second view, even in the exams, if you are given only one view. This is an X-ray of the shoulder. Again, on the anterior posterior view, it looks slightly abnormal, but again, you will not think that the joint is not located. Yeah. However, on the other view, which is the axial view, you see that the humeral head has been dislocated posteriorly. This is a posterior shoulder dislocation, which could have been missed if you only looked at the AP view. And over here, this is also known as the light bulb sign. The light bulb sign for a posterior dislocation. Now, the second principle is two joints. In this case, the patient has an ankle fracture as seen over here. It is a medial malleolus fracture. And the patient complained of some pain over the proximal aspect near the knee. So when the X-ray is repeated in the knee, what we see is a fracture over at the proximal fibula. Alright, so this is known as a mesonerve injury. What has happened is that the fracture occurred at the ankle and then the forces went up along the interosseous membrane, continuing up and then exiting at the fibula. So therefore, If you did not take an X-ray of the knee, you would have missed the mesonerve injury. This is another example. Okay, here on the X-ray of the elbow, we note that there is a radial head fracture, but the patient also complained of pain distally. Okay, and when we took an X-ray over the distal radial ulnar joint, we note that there is a dislocation over at the distal radial ulnar joint. Okay, fantastic. And what has happened is also the injury has gone along the interosseous membrane, resulting in the dislocation of the distal radial ulnar joint. This is known as an Essex Lopresti injury. Essex Lopresti. Now, the next principle is two occasions. Over here, it is a X-ray of a total hip replacement. Okay, and immediately post-operative, you can see the beautiful X-ray, a well-aligned hip, okay, with the implant inside too. Over time, 10 years later, the patient presented with pain, and we repeated the X-ray. And now we have the opportunity to compare two occasions, right? Look at this. There's an area of lucency around the lateral aspect of the implant as compared to the original X-ray, right? So with this X-ray, we can then diagnose periprosthetic loosening, for example. Now this is a total knee replacement X-ray. Post-operative, we see the X-ray over here. And 4 years later, patient has pain. We repeated the X-ray, and now we have the opportunity to compare to the first X-ray. And what we see is that there again is lucency noted along the medial aspect of the tibia component, right? So there is again periprosthetic loosening. Great. So now we've gone through the four principles, two views, two joints, two occasions, and now we're going to look at skeletally immature X-ray and how do we know that they are skeletally immature. Now on every slide, moving on here, we will see an X-ray of the adult, which is labeled, and the other X-ray is that of a skeletally immature patient. And I just want you to observe that can be quite obvious to identify skeletal immaturity. Okay, so this is X-ray of the shoulder. What we see, the distinct differences is that there is an open physis over at the proximal humerus. Right, this is not a fracture line. This is an open physis, okay, and you do not see it in an adult. Again, over here, this is an adult elbow X-ray. This is a skeletally immature elbow X-ray, and what do we see? We see open physis. Right, this is over at the capitellum. Open physis at the radial head. Okay, open physis. This one is over at the medial epicondyle. Okay, and you don't see all this in the adult. So again, by pattern recognition, we can know that these are not fracture lines, but they are open physis. This is an X-ray of the forearm over here, the adult, and the skeletally immature. We see open physis over at the radial styloid, as well as the ulnar head. And also on this view, we can again see the open physis over at the radial head, okay, the capitellum, as well as the medial epicondyle. These are not seen in the adult X-ray. Over here is over at the wrist. In the wrist, there are 8 carpal bones, which are well formed in the adult. As you can see, the scaphoid being really, really obvious here, but in the child, you do not see them. That's because they are not ossified. It does not mean they are not present. They are present in the cartilaginous form. That's why it is not picked up on an X-ray. Okay, but nevertheless, they are there, but they are not ossified. You can see the difference. This is the X-ray of the hand and the adult, and skeletally immature, again we see the metacarpals, as well as the phalanges. And again we see multiple open physes, okay, here, as well as the base of the proximal phalanx, the base of the middle phalanx, the base of the distal phalanges, okay, and this is the head of the metacarpals. Okay, so here you can see a bit more ossified carpal bones as compared to the previous x-ray. They come up in different stages. Now going on to the lower limb, you can see that this is an adult x-ray, and this is a slightly immature. We see open physes at the femoral head. Can you see that? Femoral head, and even the iliac bones are not fully formed and fused, right? Over at the superior and inferior pubic rami, as well as the acetabulum itself, right? It appears to be in discontinuity, but that is not the case. There is cartilage in between these spaces, okay? Just that they are not fully ossified as opposed to a skeletally mature patient. Over here is the X-ray of the knee. You can see the knee AP and lateral views. A skeletally immature patient will have open physes over the distal femur, the proximal tibia, and the proximal fibula. Now, the question then comes here to ask ourselves, how mature is this patient? And this is where you may have heard this mnemonic, CRETO, before. Okay, C for capitellum at 1 year, R for radial head, which comes out at 3 years, the internal or the medial epicondyle at 5, the trochlear at 7, the olecranon at 9, and the external or lateral epicondyle at 11. All right, they are all odd numbers, 1, 3, 5, 7, 9, 11. So how can we use this knowledge to guess the skeletal age of the patient? Okay, so looking at this x-ray, what we can see is the capitellum is present. I can also see the radial head for sure. Same on the lateral view. So they are minimally at least 1, 3. All right, more than 3 years old for sure. Right? Next, do I see anything over the medial epicondyle? So on the medial epicondyle, I don't see anything separate. All right? And I confirm that by noticing that there is a very minimal ossification at the trochlear. Okay? So all I can say from this patient is that it is at least 3 years old. All right? May not be 5 years old yet, based on the cretal mnemonic. All right? Fantastic. Now, if a more comprehensive way to determine skeletal age would be the use of an atlas. Okay, so this was done in a study many years ago, which may not be ethically approved because they took x-rays of normal patients, exposing them to radiation. But nevertheless, this is a collection of hand x-rays of, of young patients of various ages, from newborn all the way to 19 years. And they then know when the carpal bones start to ossify and become present, okay, in these patients. So this is how we tell the skeletally maturity of a patient based on the x-rays. Alright, so now we have covered the key principles. Remember, we always want 2 views. If given 1 view, always look and ask for the other view. If there's pain after a trauma at the adjacent joints, be sure to do x-rays, 1 joint above, 1 joint below. 2 occasions, always compare any x-rays if you have, and we have learned how to identify skeletal maturity by the presence of any open physes, and we can then also use a mnemonic at the elbow, creto, as well as an atlas to comprehensively determine the skeletal age of the patient. Alright, so now we're going to proceed on to look at x-rays of the not human anatomy. And we're going to start from the upper limbs, and then we'll go through the lower limbs, and then we will go to the spine. Okay, so let's start for the shoulder. Now, this is a normal shoulder x-ray. This is an AP view of the shoulder. Okay, so very briefly, we can see the main articulation is within the glenohumeral joint. Okay, and we can outline the scapula on this X-ray. Okay, and we can see the coracoid process and is articulating with the head of the humerus. Okay, and over here we can see the clavicle, which articulates with the acromion. Okay, which goes on to become the spine of the scapula. Okay, and this is taken with the patient standing in this manner. Okay, we can also identify the greater tubercle or the greater tuberosity of the humerus. Take note that in the lower limb is the trochanter. Here is a greater tuberosity or the tubercle. Okay, yeah, and it's very important when looking at this X-ray to also I look at the lung fields to see for any abnormalities, which you may pick up an incidental lung tumor. Now, this is an important line in the AP X-ray of the shoulder. It is known as the Maloney's arc. All right, say Maloney's arc. Now, this is also known as a Shenton's line of the shoulder. Any disruption would suggest a displacement of the humerus. Okay. Next, this is a axial view of the shoulder. Okay, you can see that the patient requires abduction of the arm to take this X-ray. You can see the humerus head that is articulating with the glenoid over here. Okay, and here you have the coracoid process and the acromion here, which articulates with the clavicle. Okay, so how do we tell from this X-ray itself where is anterior, where is posterior? You need to have a lighthouse, And in the shoulder, the coracoid is known as the lighthouse of the shoulder. Wherever the coracoid is, that is anterior. Okay, so that's a very helpful landmark to identify on a shoulder axial X-ray. Now we have some shoulder special views, right? Now appreciate again that the axial view requires abduction of the arm. And this may be painful in certain situations, right? If the patient is in the arm sling, it may be hard to obtain this X-ray. So the option that we have here is number one, a wide scapular view, which involves the patient standing next to the X-ray board, and the X-ray is shot in this manner in the plane of the scapula. Now that is why the scapula now appears as a Y shape, and that's why it's known as a Y scapular view. On this view, take note that the humeral head is directly centered on the glenoid. So if the humeral head is anterior, where the ribs are, then it will be an anterior shoulder dislocation. If it goes posteriorly, then it will be a posterior dislocation. Okay? The other view that we have is the Valpue view. The Valpue view is also a comfortable view which does not require abduction of the arm. The patient simply leans backwards and the X-ray is shot from superior to inferior. The patient can still be in the arm sling and is more comfortable. And here, appreciate again that you can see the humeral head with the glenoid, the clavicle in front. And here again, you can identify whether the humeral head is dislocated anteriorly or posteriorly. Another special view that we use to look at the acromioclavicular joint, something very common, is the Zanker view. It is shot 30 degrees, 10 to 30 degrees in the cephalad direction, all right, that allows us to look at the acromioclavicular joint. Now, in orthopedics, it's about comparison. Okay, so we can also do a bilateral Zanker view, which allows us to compare both acromioclavicular joint, and in particular, we can also look at the coracoclavicular distance, and we can compare both sides. You can see on this slide here, on the left side, it has increased, suggesting that there is an injury to the acromioclavicular joint. Now, I'm just going to show you some abnormal X-rays, and I want to give you confidence that you are able to tell something's abnormal simply by knowing what is normal. Right, look at this X-ray. You can tell there's something abnormal with the glenohumeral relationship. There is a disruption of the Maloney's arc for sure, right? So on the AP view, there is a dislocation of the shoulder, And on the Y-scapular view, we can see that it has gone anterior. So this is the anterior shoulder dislocation. Now over here, we can see that the beautiful symmetry and the smoothness of the bones that God has designed for us is disrupted. So this is simply a proximal humerus fracture. Now we move on now to the humerus shaft and down to the elbow. All right, so a normal numerous X-ray, we have a anterior posterior view. All right, the patient standing in this way. We can see once again the greater tuberosity, okay, of the proximal humerus, and going down, we can see the lateral epicondyle as well as the medial epicondyle. And this is the shaft of the humerus. On the lateral view, very similarly, we can see the entire shaft, and this is the elbow part of it, at least. And a good lateral, all right, bear in mind, you will have the medial and lateral epicondyles directly superimposed beautifully. All right, and you see a circle over there. So this is the AP and lateral of the humerus. As we move down further, this is what you can order in the elbow as well, AP and the lateral elbow. Right, so on the AP, well, it serves well for you to identify a landmark to know where is anterior, where is lateral, and where is medial. All right, and the useful landmark will be the radial head for me. Look, where the radial head is, this is lateral. So the lateral epicondyle will be here. The radial head articulates with the capitellum. Okay, will be the medial epicondyle. So therefore, this will be the ulnohumeral joint where the coronoid process articulates with the trochlea. The trochlea. Okay, and of course the radius and the ulnar bones. And on a lateral view, a good lateral view, again, you see a perfect overlap of the epicondyles. So you get a nice circle here. And here we can see the radial head. We can see the coronoid process that overlaps the radial head. Okay, the olecranon process that is part of the ulna and the shafts of the humerus. Okay, AP and lateral elbow X-ray. Now, I just want you guys to appreciate that you can see that there is a great overlap of the radial head, right? Great radial head over there, and there will be a special view that I want to show you guys later on that. But now we look at two lines for the elbow, which is very, very pertinent in a pediatric case. Okay, the first of which is the anterior humeral line. The anterior humeral line. Basically, a line drawn down the anterior surface of the humerus should intersect the middle third of the capitellum. The anterior humeral line. Now, how is it helpful? Well, for example, in this case, an anterior humeral line going down does not intersect the middle third of the capitellum. This suggests there is a very mildly angulated supracondylar fracture which resulted in an extension of the distal humerus. So therefore, it now does not bisect. There is a supracondylar fracture in this X-ray. Another one over here, anterior humeral line does not bisect the capitellum. There is an injury, alright, over the supracondylar region. One more, anterior humeral line does not bisect the middle third. There is an injury. Okay? Now the second line that we want to learn about is the radial capitellar line. The radial capitellar line, a line drawn down the neck of the radius on any view should intersect the capitellum. Alright, AP view, lateral view, it should intersect the capitellum in this way. Right, look at this. In this case, the radial capitellar line does not intersect the capitellum. There is a dislocation of this joint. Similarly to this, right? The radial head does not intersect the capitellum. There is a dislocation over the proximal radial ulnar joint. These are two lines in the elbow that you should be aware of, the anterior humeral line and the radial capitellar line. Now, just now we mentioned that the radial head is very much overlapped. So therefore, you want a special view if you find that you want to look at the radial head better. And this is called a Greenspan view. It is simply shot in an oblique manner such that the radial head is now no more overlapped with the coronoid process. And now you can see it in its entirety. The Greenspan view. Now, in the elbow x-ray, we have some special x-ray for the pediatric population as well. Now we saw that just now there was an elbow anterior posterior. I want to introduce you to this internal oblique view, whereby the forearm is simply um, pronated inwards to get an internal oblique view at the elbow. Now let me show you an example of this. In the elbow AP, alright, you vaguely see any injury on the lateral epicondyle. Alright, but in the internal oblique view, alright, the fracture at the lateral condyle is now visualized better. So this is very helpful in looking closely for a lateral condyle fracture. Okay, good to visualize the lateral condyle fractures, which is the second most common pediatric elbow fracture. Alright, again, another one, elbow AP and the internal oblique view. Now you can see the fracture down the lateral condyle. Alright, so this is commonly seen in a pediatric orthopedics clinic. Now, just a quick brief overview of some abnormal x-rays. Now, here you can see very obviously a humeral shaft fracture. Okay, in this case, if you are sharp, you will realize that this is a skeletally immature patient. Alright, there is open physis both proximally and distally. Now, this is an adult patient, skeletally mature. There's again a humeral shaft fracture. This is a distal humerus fracture. Alright, the beautiful symmetry is disrupted with a very comminuted distal humerus fracture. Now moving on to the forearm. What do we see in the forearm? This is a anterior posterior view. We can see better some of the elbow bones as well, the radial head, and then going down is the radial styloid. Okay, and the ulnar head and the proximal olecranon. Yeah, so take note, right? The head of the ulna and the radius is on opposite ends. The radial head is proximal, but the ulnar head is distal. So this is how you shoot a normal forearm x-ray, AP. And this is a lateral view. Again, a good lateral, good superimposition of the condyles, of the medial and lateral condyles. And you can see both the radius and the ulna in this manner. Okay, AP and lateral forearm x-rays. Now we're going to look at the normal wrist x-rays, and we'll also learn some of the lines called the radial parameters. Now this is a wrist PA. Now take note, it's now PA because why? The beam is now shot from posterior to anterior. Okay, and here we can see mainly focusing on the distal radius as well as the carpal bones. It is very crucial for us to learn the carpal bones, okay, of which there are 8 of them. Now this is a lateral view of the carpal bones with significant overlap. Okay, shooting a lateral view. Number one, you need to know the bones. So there are some mnemonics that you can learn, okay, to remember them. So this is a scaphoid. Yeah, scaphoid with the lunate next to it. The triquetrum, as well as the tiny pisiform. And then going back to the thumb side again, with first bone is a trapezium. Because trapezium starts with a T and has an M, it is articulating with the thumb. Alright, trapezium. Trapezoid. Okay, the capitate is the huge one in the middle, and the hamate together with the small hook that can see some overlap there. So this will be the carpal bones. And a line that's crucial here is the gillulus lines, of which there are 3 of them. There is the proximal aspect of the proximal carpal row, the distal aspect of the proximal carpal row, and the proximal aspect of the distal carpal row. So in a normal APA view, they should be very, very smooth. Alright, as you can also see here, there is a proximal row, alright, with the 2 lines as well as the distal row. So the gillulus lines. With regards to the distal radius, there are these radial parameters which are the rule of 11. Alright, what are they? Now on the PA view, you should see the radial inclination, alright, should be at 22 degrees over here. Alright, this is the radial inclination, 22 degrees. Next, the radial height, alright, which can help us look for radial shortening, should be 11 mm. Okay, this is the radial height. And finally, on the lateral view, we can look for a normal volar tilt. That means the hand is actually tilted volarly, tilted towards the volar or palmar aspect. So if you see a dorsal tilt, then that will be going opposite, and that means we may have fracture over the distal radius. But these are the radial parameters: inclination, radial height, and the tilt. Okay, and you can see they are all something to do with 11s, 22 degrees, 11 mm, 11 degrees. Now, there's some special views for the wrist. You may not see them that often, but they are interesting to know. Number one is a carpal tunnel view. As you can see just now, there was the hook of Hammett, which cannot be well seen on a PA view. But when you do a carpal tunnel view in this way, you can actually see some of these carpal bones and the pisiform as well. Very interesting. This is a scaphoid view, something that is more crucial for you to know. If there is pain, for example, in the anatomical snuff box, and your usual PA and lateral x-rays are normal, then it will be prudent to order a scaphoid views, which will involve further manipulation of the wrist to look at the scaphoid better. Okay, so one of them is that with an ulnar deviation, all right, to kind of show the scaphoid a bit better, and also a semi-pronated oblique view, which again helps us to look at the scaphoid better through different angles. Okay, remember, the X-ray is a two-dimensional imaging. The more views you have, the more angles that you have to look at, okay, to look for any small fractures. Now, this is a normal hand X-ray. As we move down distally, almost towards the end of the upper limb, we see the hand now. Now you see more of the fingers, the metacarpals, of which we have 5 of them, the proximal phalanx, okay, the middle phalanx, you only have them on your uh, lesser fingers, and then finally the distal phalanx, also on the thumb. Take note, the thumb only has 2 phalanges, okay? Now this is a lateral view. You can appreciate a classic lateral view, well shot. You will see very distinct overlap of the metacarpals, and appreciate that this may be hard to look for fractures. Therefore, you can do an oblique view, which is part of the package, so-called, to remove all the overlapping of the metacarpals. All right, so hand PA, lateral, and oblique. This is a standard set for the hand. Now, further distally, we have the finger, okay? And here we have the PA, oblique, as well as lateral views of the finger as well. Okay, very good. So now a quick look at some abnormal x-rays now. Wow, this is a forearm x-ray which shows a fracture of both radius and ulnar shafts. In addition, what happened? There is also a posterior dislocation of the elbow. Yeah, so it's a very complicated injury. And you can see that on this x-ray. This is a distal radius fracture. Now take note of a few things. Number one, you can see it's an extra-articular comminuted fracture, multiple pieces. We can see the radial inclination is now lost. It's supposed to be 22 degrees, but now it is horizontal. The radial height, which was supposed to be 11 mm, is now less than 3 mm, for example. And look at this x-ray over here. There is supposed to be a volar tilt in this direction that my laser pointer is showing, but now it becomes a dorsal tilt. It is tilting dorsally. This is the back of the hand. So it's tilting dorsally. So these parameters are disrupted in the distal radius fracture. Yeah, and this is actually on the finger. It shows a bony mallet. There is a avulsion of the distal phalanx base. All right, so these are abnormal forearm, wrist, and hand x-rays, as well as the finger. Now, we are now going to move into the lower limb x-rays. If you have any questions at all, you can feel free to drop me a message on social media or Telegram, and I'll try to reply you. Okay, but now we're gonna go on into the lower limb x-rays. Okay, starting with the pelvis and acetabulum. Now, in the normal pelvis x-ray shot in this manner, okay, you can see both hip joints. That's the advantage of a normal pelvis x-rays. You can compare both sides. Okay, so here in particular, we can see the ilium. All right, we can see the superior and inferior pubic rami. Okay, as well as the ischial tuberosity. Okay, and for the femur itself, take note the terminology of a greater trochanter as well as a lesser trochanter. Okay, this is a pelvis AP X-ray. And on this X-ray, it is useful to look at some acetabular lines. These are probably not expected in the undergraduate level, okay? But you can appreciate that the various lines of overlap, if you look closely, you can tell that they are corresponding to different anatomical landmarks in the normal anatomy. All right, we have the ilioischial line, the iliopectineal line, the teardrop, the acetabular fossa, all right, the anterior wall of the acetabulum and the posterior wall of the acetabulum. Okay. Now appreciate that there was lots of overlap. Okay, and even in the pelvis, it may be hard to identify fractures in the pelvic ring. So therefore, we have two special views for the pelvis, the inlet as well as the outlet views. Now, by now, you should realize that special views are simply X-rays shot in an oblique manner. That means not directly perpendicular in an orthogonal fashion, but then oblique view, all right, which allows you to look at through a different angle. And here you can see an inlet view. Simply the X-ray is tilted 45 degrees towards the head and is shot in this manner. And then you get a unique view of the pelvis. You can see that this is the inlet view. All right, in other words, you're looking at the inlet of the pelvis. If you tilt the angle 45 degrees to the other side, then you get an outlet view. An outlet view. You can see it drastically changes how it looks like on the X-ray. And here, you can see that they both give good functions. Right? For example, when you look at the inlet in this manner, you can appreciate that it is very useful to look at anterior and posterior translation. All right, just let it settle in your mind first. It's very good to see if that one side goes anteriorly. Yeah. As opposed to an outlet view, it is good to look at superior inferior translation because of the angle. You can see if one side goes upwards. All right. So the inlet is good for anterior posterior translation. The outlet is good for superior inferior translation. Now, with regards to the acetabular lines that we saw, you notice there's lots of overlap. And again, we know that it's all about shooting oblique X-rays to get a special view. And here we have a what we call an obturator oblique view. Well, you can remember that by simply noticing that the obturator is better seen as opposed to a anterior posterior view. Right here you see it very nicely. It's an obturator oblique view, and the advantage again, you can see the iliopectineal line with minimal overlap. Right, so this is very good. Look at the iliopectineal line. And then this is an iliac oblique view. Now realize then that now you can see the ilium very well. Okay, that's why it's called the iliac oblique, and you don't see the obturator foramen. And this is really good, all right, to look at the ilioischial line. So they have different functions, right? And it's simply shot as mentioned in a tilt of 45 degrees. Okay, and a simple mnemonic for me is this thing called PICO, right? PICO. I'm sure you've heard of this in terms of research kind of stuff. But here we see that the posterior column, all right, is best seen on an iliac oblique view. Right? If you recall, the posterior column is visualized by the ilioischial line, and the ilioischial line is so obvious here, right? Therefore, it is good for the posterior column and the corresponding anterior wall, and the opposite will be true for the obturator oblique view, all right, which is good for the anterior column because of the iliopectineal line and the opposite posterior wall. But again, these lines are not required in the undergraduate exam, so do not panic. You will not be asked to interpret these lines in your exams. Now, a quick look at some abnormal pelvis x-rays. This is a straightforward pelvic, open book pelvic fracture. You can see the disruption of the pubic symphysis as well as the sacroiliac joints. Over here is the acetabular fracture. Well, notice that there are many fracture lines that the lines that we talk about are now disrupted. Okay, now moving down to somewhere more important, especially for undergraduate students, would be the hip and femur. Now, hip X-ray very crucial. Notice if you order a hip X-ray, you can only see one side. Right, so often we order a pelvis X-ray as well as a lateral view so that we can at least compare both sides. Nevertheless, it's a hip X-ray on the one side, on the left, and really focus on the key things you look out here: the obturator foramen, the ischial tuberosity, okay, the ilium, okay, and then over here we have the femoral head, the femoral neck is here, all right, and then it goes on to the greater trochanter and the lesser trochanter, all right. Know the muscles that attach to each one. All right, the greater trochanter is where all the abductor muscles, the external rotators such as the glutes, the piriformis, all attached to the greater trochanter, while the lesser trochanter, the iliopsoas attaches there, which does flexion of the hip. All right, so there's a hip AP X-ray. Over here, the most important line, everybody, the most important line in orthopedics in the undergraduate level is the Shenton's line. You need to repeat after me, Shenton's line. And this line shows that, all right, that it is very smooth, all right, going down the femoral neck and down to the shaft. It is undisrupted in a normal X-ray. Now, this is a lateral view of the hip. Okay, you can see the femoral head articulating the acetabulum. Okay, and of course, part of the lesser trochanter as well as the greater trochanter. Now, this is a femur, a normal X-ray. Sometimes it is not long enough, so you need more views to look at the entire AAP. Okay, you can see all the structure that we talk about, and now you can see the entire shaft. Okay, and the lateral view, again, to accommodate for the length, you may need more than one X-rays. And a good lateral would involve a good superimposition of the medial and lateral femoral condyles. Just a quick look at some abnormal X-rays now. This is a subtrochanteric fracture. Okay, the fracture has occurred below the trochanter, and most importantly, the line here is the Shenton's line. So this is a Shenton's line that is intact. Yeah, you can see that it is disrupted on the other side. There is a displaced subtrochanteric fracture. Now this is a femur shaft spiral fracture that we can see here in this X-ray. Now moving down to the knee we have the femur as well as the tibia with the fibula. All right, this is the AP view. All right, how do you tell medial lateral? You need to have a landmark, and that would be, I would say, it could be the fibula. Right, wherever the fibula is, that is lateral, and now you know this is lateral femoral condyle, the medial femoral condyle. Okay, you can also know that this is the lateral tibia plateau and the medial tibial plateau. Right, and the patella is superimposed over here. Now on the lateral view, again, a good lateral, good superimposition of the femoral condyles. The patella you're looking from the side view, and the fibula is somewhat posterior, all right, with some overlapping. Okay, this is a lateral view. But one thing to note, in the AP, a good AP will have slight overlap of the fibula head. A slight overlap of the fibula head would suggest a good AP of the X-ray of the knee. Now take note of this thing here. Weight bearing will reveal the loss of joint space better. Right, so if you're doing X-rays to evaluate for osteoarthritis of the knee, where we expect to have some loss of joint space, it is prudent to order weight bearing. All right, because if you ask the patient to take a supine X-ray, then the joint space may look to be falsely intact. So weight bearing will accentuate the loss of joint space. Now, a good special view to learn about the knee will be the skyline view, which is shot in this manner. It allows us to look at the patellofemoral joint. The patellofemoral joint. Now, more special X-rays of the knee would be the Rosenberg view. A Rosenberg view involves the patient flexing the knee slightly and then shooting the X-ray And this actually helps us to look at the medial compartment a bit better. What do I mean by that? Look at this X-ray over here. In extension, it appears to have a good joint space. But when we ask the patient to flex a little and we shoot the X-ray again, we can see that there's definitely bone-to-bone contact over the medial compartment. So the Rosenberg view can be used in certain decision making for certain surgeries in orthopedics. All right, you probably will not be ordering this X-ray on your own, but it will be left for the specialist. Another special X-ray view would be a long leg film. A long leg film which will help us to objectify the extent of various or valgus deformity that you may also see clinically. All right, so over here it is a long leg film, and what you need to learn to do is to look at the mechanical alignment. The mechanical alignment, and you draw a line from the center of the hip through the center of the ankle. It should pass through the center of the knee in a neutral alignment. So in this case, what we see here is a various alignment. All right. In this case, if we do the same thing and we draw a line from the center of the hip to the center of the ankle, what happens? The center of the knee is actually medial to this line, and therefore this is a valgus deformity. On a long leg film, we can actually measure these angles and be objective in describing the extent of varus and valgus deformity. Now, when we're going to look at some abnormal X-rays now of the knee, here you can see a distal femur fracture on the AP and lateral view, intra-articular comminuted fracture. And here we can see that there is disruption of the beautiful symmetry again. And on the anterior as well as the lateral view, this is an anterior dislocation because we reference from the distal fragment. It has gone anteriorly. So this is a knee anterior dislocation. Now moving on further, we'll be going down to the tibia and the ankle. This is a normal tibia X-ray. You can see the entire tibia, okay, with the tibia as well as the fibula. And of course, whichever you use to orientate yourself, the fibula will be lateral for me, okay. And of course, you can see the fibula goes on to become the lateral malleolus, okay, of the ankle, while the tibia goes down to become the medial malleolus of the ankle. Now on the lateral view, you can appreciate again a slightly posterior position of the fibula. Okay, you can see the side of the patella as well. And this is the tibia X-ray. Now in the normal ankle X-ray, what we see here is that we can see the tibia which goes on to the medial malleolus and the lateral malleolus of the fibula. Okay, and this is a beautiful X-ray of the talus, which articulates with the tibia as well as the fibula. On the lateral view, you can also see the tibial-talar joint. Okay, this is the talus over here, the fibula with slight overlap. Okay, and the calcaneum, which is over here. Take note that the calcaneum does not articulate with the tibia. It is a talus. All right, the talus. Now appreciate that on the AP view, you may not be able to see what we call the mortise very well. That means there's certain kind of overlap, especially on the lateral side. And that is where we have a mortise view, which is slightly internal rotation of the foot. And here you can see the entire mortise in its entirety, right? And this is how you determine the various lateral and medial clear spaces. Ankle mortise view. Okay, some abnormal X-rays of the tibia. You have see a proximal tibia plateau fracture, a lateral one because the fibula is over here. This is a tibia shaft comminuted fracture. Okay, and over here also a distal tibia comminuted fracture. Now moving further distally would be the foot. The foot here, yeah. So over here we have X-rays of the DP. Okay, you can see that you can see the various bones. I think it's important to know the bones. So there will be some overlap of the calcaneum. Calcaneum is over here. This is the talus that articulated with the tibia. And then the talus goes with the navicular. The clavicular, then there will be three cuneiforms, medial, intermediate, and lateral. And the cuboid that articulates with the fourth and fifth metacarpal. Okay, and here you can see the various metacarpals or metatarsals, I beg your pardon. In the foot is the metatarsals, in the hand is the metacarpal. Okay, and again, similarly to the thumb, the big toe only has two phalanges, but the other toes have proximal, middle, and distal phalanges. Okay, and by convention, we also know from the metacarpals the base is always the proximal aspects of the bones, while the head is the distal aspect. Okay, here's a good lateral of the foot. You can see again a lot of overlap of the metatarsals, and therefore you want to have a oblique view. You want to have an oblique view to remove the overlap, by the same time giving you two views that you can assess the bones with. And here you can see a lesser overlap of the various tarsal bones. You can see the cuboid better that goes with the fourth and fifth metatarsals, the lateral cuneiform that goes with the third, the intermediate that goes with the second, and the medial that goes with the first, the navicular that articulates with these three cuneiforms, and the talus. Yeah. Now here we have a lateral weight bearing view. Now this is very helpful when you want to evaluate for things like pes planus, flat foot, right? When you weight bear the patient, you allow gravity to collapse the arch to evaluate the severity. So we're just using gravity when we are doing weight bearing views, right? Thank God for gravity that allows us to do that. Now, as we move more distally, we can look at the calcaneum. This is a calcaneum X-ray view, right? Lateral view of the calcaneum, which articulates with the talus at the top. Okay. Um. Yeah. And what other views do we have here? We have the axial view. Usually in this manner, you can look at the calcaneum from the other angle, and the Broden's view, which is a oblique view of the calcaneum. These are used to evaluate for calcaneum fractures. Okay, calcaneum fractures. Now, distally, we have the toes. All right, we can look at the toes. Okay, individually. Again, the big toe only has two phalanges, while the other toes have three. And this is an oblique view again. All right, because to remove the overlap, you can look at the various bones that you would like to evaluate for any injury. Looking at some abnormal foot x-rays. Now, this is a x-ray showing a fifth metatarsal fracture, all right, along the shaft. Yeah, so this is the base, this is the head. Now, this is the shaft. There is an oblique fracture of the shaft of the fifth metatarsal. Now, this is a talus fracture over the neck area, the talar neck fracture. This is a calcaneum fracture. Okay, calcaneum fracture. Fantastic. So now we have completed upper limbs and lower limbs. You have really seen the entire spectrum of x-rays that you can order for your patients if they have pain in any of these areas. Okay, and you also know now the special views that you can do to look at particular areas of the bones that may be overlapped, okay, in the standard orthogonal view x-rays. Now we're going to the cervical spine. All right, and here we have the anterior posterior view. You shoot the spine and you can see the various vertebral levels. Okay, here is a lateral view, and a lateral view is very, very helpful to then count where the level we are talking about. And we usually by convention start with C2 because the C2 is the largest vertebrae. It is also known as the dens, right? It's a C2 that I'm highlighting here. Okay, C2 also has a large spinous process. Okay, so C2, 3, 4, 5, 6, 7, and T1. You do not have the C8 vertebrae. Yeah, and here actually this is very interestingly, if you go down at the middle of your spine and the first vertebrae, the first hard prominence that you feel would actually be this thing called the vertebral prominence, which is your C7. So you can actually have a surface landmark of C7, okay, on your own right there. Okay, All right, so remember, count from C2, that's the most accurate. C2, 3, 4, 5, 6, 7, and you describe abnormalities by the level like, oh, C45 or C56 kind of thing. Okay, and there are some special lines that you also want to look at here because I will be describing them later. But take note that on the X-ray, on the lateral view, you can also look at soft tissue. Soft tissue. Okay, so this may be prominent when there is retropharyngeal swelling, which I will then show you now in the important lines for the cervical spine. Number one, you need to know the 4 lines for cervical spine alignment. You need to know these lines, right? Look at this. The anterior vertebral line, the posterior vertebral line, the spinal laminar line, as well as the spinous process lines. All right? God made these lines to be very, very smooth and flowy. Any abnormality would suggest some kind of shifting of this vertebra. For example, in this case, right, going down the anterior vertebral line, oh no, it's disrupted over here. The posterior vertebral line is disrupted. Yeah, and so are the rest of the lines. Yeah, so there is an abnormality. There is a spondylolisthesis. Of which level? You count from C2, 2, 3, 4, 5, 6, 7, T1. So 7, C7, T1, there is a spondylolisthesis. How about this? All right, you see, can you see the flowy lines going down the anterior vertebral line? Hey, there is a slip here. There's also a slip here, right? So what is the issue? You come from C2, 3, 4, 5, 6. So this is C5, 6. Okay, facet dislocation in this case. Yeah, so it's very, very crucial to look at these 4 lines and be very, very familiar to look for them, to look for cervical spine alignment. Now, the other crucial set of lines would be to look at the retropharyngeal soft tissue, right? And I mentioned that earlier that you can see the soft tissue, even on this X-ray, you can see the soft tissue contours you can see here. And the very good rule that we can think about is the 2662 rule. What does that mean? That means at the C2 level, there should be a maximum of 6 mm of soft tissue shadow. And at the C6 level, there should be a maximum of 22 mm. 22 mm. Okay, so give you an example over here. So C2, or this is a normal example, right? So C2 over here and C6, 2, 3, 4, 5, 6. At C6, this should be 22 mm at maximum. This is an example here. Can you look at this X-ray, right? You can see directly at the C2 level, there is retropharyngeal swelling. More than 2 mm, there is something abnormal here. How about this? Similarly, at C2, it is more than 6 mm. So there's abnormality. So remember to look at the soft tissue by the 2662 rule to assess for retropharyngeal soft tissue swelling. Now, the special views for the spine would involve a flexion extension views, all right, asking the patient to flex normally to shoot and to extend maximally to shoot. And you want to look at any displacement of the various vertebral bodies, okay? And this is to look for dynamic instability. Dynamic instability, all right? Now, there's some special X-rays which has been largely replaced with a CT scan. Now, this is a open mouth odontoid view. All right, this is to look at the odontoid process. The odontoid process, which is the C2. The C2. Okay. Over here is the swimmer's view. This is look at the lower vertebral bodies by asking the patient to extend one arm, as well as to really pull down the neck to look at the like a swimmer, right? They're doing a freestyle breathing kind of action. The swimmer's view to look at the lower vertebral bodies. Some abnormal X-rays over here, you can see that looking at this X-ray, you can appreciate that the anterior vertebral line is disrupted. There's something wrong here, okay, but the posterior vertebral line is intact. So it's going on here, and this is a C3 teardrop fracture. How we know C3? We come from C2, 3. So this is C3. Now this is cervical spondylosis. Simply means some wear and tear degenerative changes in the vertebral bodies. And how do we know the level from here? 2, 3, 4, 5, 6. So C5, C6 spondylosis is present. Okay, the alignment is still intact because the anterior vertebral line, the posterior vertebral line, the spinolaminar line, and the spinal process line, they are intact. Okay. Meanwhile, you can also look for any retropharyngeal swelling, 6 mm at C2. All right. And then you measure 2, 3, 4, 5, 6, 6. Make sure that it's less than 22 mm. Okay. In fact, on this X-ray, we can appreciate that it could be, I suppose it's still normal. Yeah, it's 6 mm at the C2 level. Now, moving on to the lumbar spine. In the lumbar spine, look at the normal X-ray again, AP. Okay, it's useful to learn how to count the levels, and I think it's good to use the T12. The T12, you know, there are ribs, and definitely below will be L1, L2, L3, L4, L5. Okay, and that's where you can see the spinous process that is superimposed posteriorly, and it's crucial, highly crucial to attempt to look for the pedicles. The pedicles. Any missing pedicle will be the winking owl sign. A missing pedicle is a winking owl sign, suggests of a lytic metastasis eating up the pedicles. All right. So of course on lumbar spine AP, you can also see part of the sacrum, the sacroiliac joints, and the ilium. Now this is a lateral view. A lateral view, you may appreciate that it may be hard to look at the ribs to count now, right? So you want to use the sacrum. S1, L5, L4, L3, L2, L1. Okay, and you can see the intervertebral body space. Intervertebral space. Okay, you can see that here. Any loss of space would suggest that the disc is degenerated and not present, and it's almost like loss of joint space in the other joint kind of thing, right? So there will be arthritic changes, but in the spine is termed as spondylosis. Spondylosis, okay? Now, I just want to make a note here on counting the levels, all right? Because every time we count from S1 from the bottom, you may get it right, okay? But sometimes there is what we call a sacralized L5. It means the L5 is now fused to the sacrum. And you can wrongly count that as a S1 and then proceed upwards in an erroneous fashion. And the other opposite can be true. You can have a lumbarized S1, meaning part of the sacrum is now appears to be separate. And now you think it is a L5, but it actually is an S1, right? So in essence, a lumbarized a lumbarized sacrum may make you count wrongly, and a sacralized L5 can also make you count wrongly. So therefore, honestly, the gold standard is really counting from the cervical spine, C2 onwards, downwards. All right, and that can be done perhaps in a X-ray that allows you to see the whole spine, or even in an advanced imaging like CT, MRI. The gold standard is still counting from the C2. All right, but the surrogate here is to count from distally. Just be aware of this limitation. All right, or if you are asked in the exam, oh, what if there is this lumbarized or sacralized vertebra? Then your response is that you want to take a full length spine X-ray and then to count from the C2 or to look at the advanced imaging. Okay, nevertheless, we are also flexion and extension views over here. All right, to look for dynamic instability. All right, repeat after me, dynamic instability. All right, asking the patient to flex maximally, extend maximally, and to repeat the shot. Okay, and to look for changes in the displacement of angulation or translation in the vertebral bodies. Now, special views here, we have an oblique view, which is to look for the classic Scotty dog sign in spondylolysis. Okay, but nowadays we do largely CT scan to evaluate for that. Okay, the Scotty dog. The Scotty dog is intact in a normal X-ray, but if there's a collar, it means that there's a fracture over the pars interarticularis. The pars interarticularis. Now, this is a sacrum and a normal X-ray. Here you see a sacrum. All right, so maybe a patient fell directly on the buttocks and the patient has pain directly on the coccyx. This is what you order. You can order a sacrum X-ray and you see the coccyx really well over here. All right, and of course, we are assuming this is S1. And a secure iliac joint X-ray can be done to look particularly as SIJ. Maybe you are concerned about sacroiliitis in ankylosing spondylitis. You can do a sacroiliac joint X-ray to look particularly at the sacroiliac joints. A quick look at some abnormal lumbar X-rays over here. Is a burst fracture. Okay, how do I know that L1 is involved? Well, so this is T12, right? So this is L1. And the key sign to identify here is a widened interpedicular distance. Right, repeat after me. A widened interpedicular distance, right? Meaning what? Look at the interpedicles. Pedicles, pedicle, interpedicular distance. Pedicle, pedicle, interpedicular distance. Appreciate that at L1, suddenly it has increased significantly in terms of the distance, but at L2, it has gone back to be narrow. So the problem is in L1. And because the middle column of the vertebral body is disrupted in a burst fracture, there is a widened interpedicular distance. Now, on the lateral view, the corresponding view on the same vertebrae, what we see here is a retropulsion. A retropulsion, right? This anterior vertebral line, the posterior vertebral line is disrupted, and there is a fragment of the vertebral body that has gone into the spinal canal. So there is backwards, retropulsion of the vertebral body. So these two will indicate there is a burst fracture. Now this is as opposed to a compression fracture. I do not know the level because I'm not able to count from either the top or the bottom. But a compression fracture will only involve the anterior column. All right. Therefore, there is no retropulsion. The middle column is intact. So it's the anterior compression wedge fracture only. Now, this is a L5S1 degenerative disc disease, also known as spondylosis. Again, you're counting from the sacrum, and this is L5. So L5S1, there's loss of this space. All right. So this suggests that there is some spondylosis going on here. All right. In fact, now we have come to the end of the session, and I've done up this summary table of all the potential X-rays. All right, you can see of the various region that you can order: shoulder, humerus, elbow, forearm, and so on for the upper limb, going down to the pelvis, going down to the lower limb, as well as the spine. You can see that. Now, in italics, I have included the important lines that you need to know. Right, shoulder, Maloney's arch, the anterior humeral radiocapitellar lines in the elbow, especially in the pediatric case, the glenoid lines, the radial parameters, the rules of 11s, the acetabular lines, the Shenton's line is the most important in the hip. Okay, going down we have the 4 lines, the vertebral alignment, that is crucial. Of course, they can also evaluate for the soft tissue, but that is not directly important in orthopedic setting. Okay, and then we have the showing you the orthogonal sets. What are they ordered as, right? AP axillary views, or rather axial views, AP lateral, lateral oblique, right? Remember to remove the overlaps. Okay, weight bearing for osteoarthritis in the knee. Okay, and then finally the special views, right? Such as the Y-scapular view, the Zenka view, the Valpue view in the shoulder, the Greenspan view, the internal oblique view for the interlateral condyle fractures, scaphoid special views, carpal tunnel, iliac oblique, obturator oblique. Alright, Skyline, Rosenberg, long leg for mechanical axis, Harris, Brodens for the calcaneum, and some of these special views, flexion extension, especially for the spine. So in this set of this slide here, you can look at the summary table of all the potential X-rays. Okay, so with that, we have completed our goals. I hope I've achieved them. Number one, I hope you understand the key principles in ordering X-rays now, and also what you can order, right, in terms of evaluating your patient's pain in those regions. All right. So with that, thank you very much for joining me today, and hope you also can try out the quizzes that I've given you, as well as the deck of flashcards and let me know if I can help you in any way. Alright, take care guys.